Hi, I'm Dr. Neil Talwar. I'm an assistant clinical professor of medical oncology and hematology at City of Hope Upland, and I'll be presenting on blood cancers and women's issues. So what are blood cancers? Blood cancers, also called hematological malignancies, are a group of diseases caused by abnormalities or mutations in white blood cells, or WBCs. This leads to the WBCs being overproduced. WBCs are typically responsible for fighting off infection, so a cancer of these cells will make patients more prone to catching infections. WBCs are produced in the bone marrow and are housed in the lymph nodes throughout the body. These two locations are typically where blood cancers arise. There are multiple types of blood cancers, and the type that arises is determined on which one of the various differences in white blood cells in our body become abnormal: the red blood cells, the white blood cells, and the platelets. The red blood cells are responsible for delivering oxygen to our bodies. The platelets are responsible for helping our blood clot, and the white blood cells are responsible for fighting infections. So when too many white blood cells grow, it crowds out the ability of the body to make red blood cells and platelets, and can lead to anemia and also lead to bleeding. What are the different types of blood cancers? Listed here are the most common types of blood cancers that we typically see in patients. Under the category of leukemias, there is acute myeloid leukemia, chronic myeloid leukemia, acute lymphocytic leukemia, and chronic lymphocytic leukemia. Under the category of lymphomas, there's non-Hodgkin's lymphomas and Hodgkin's lymphomas. The most common types of non-Hodgkin's lymphomas that we see are diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, and Burkitt lymphoma. There's a third type of blood cancer, which is a cancer of the plasma cells called multiple myeloma, which we also see frequently. So how common are these blood cancers? So in the US in 2020, there's an estimated 178,520 people that are expected to be diagnosed with one of these cancers. That makes up about 10% of the estimated 1.8 million cases of cancer that are expected to be diagnosed this year. There are about 1.3 million people either living with or are in remission from blood cancers in the US. In terms of the estimated new cases of leukemia, lymphoma, and myeloma, lymphoma is estimated to make up the majority of these cases with a total of 85,720. Leukemia is the next most common, making up about a third of the cases, and multiple myeloma makes about 20% of all blood cancers. As you can see from this figure, blood cancers tend to be slightly more common in males than females. However, blood cancers are still quite common in females, with non-Hodgkin's lymphoma being the 7th most common cancer and leukemia being the 10th most common cancer. They are also the 8th and 9th leading cause of cancer death in females in the United States. There's estimated to be about 57,000 people that die of leukemia, lymphoma, or myeloma this year in the United States. That makes up 9.4% of all cancer deaths this year. As you can see from this figure, we have been doing much better, however, in preventing cancer death from these conditions. And all the trends from 1960 to this decade, we can see that myeloma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and leukemia, there are a much greater proportion of people surviving than there were back many years ago. So our treatments are continuing to get better, and we expect them to continue to get better in years to come. There are some risk factors that can predispose people to these blood cancers. Again, as we discussed, males have a slightly higher chance of getting these cancers than females. Also, something that's very important, especially in the female population, to know is that previous exposure to chemotherapy can lead to leukemias. Agents that are used commonly to treat breast cancer have been shown to cause leukemia several years later. These agents include adriamycin, also called doxorubicin, and cyclophosphamide. Other risk factors include exposure to radiation, and that can be radiation from cancer treatments, nuclear radiation, or workplace exposures. Chemicals such as benzene, which is commonly found in cigarette smoke, cleaning products, art supplies, paint strippers, glue, rubber, oil, and gasoline. There are some genetic syndromes associated with the development of blood cancers, and that include Down syndrome, Fanconi's anemia, Bloom syndrome, and ataxia-telangiectasia, among many others. There is also a higher chance of getting blood cancer if you have a first-degree family relative that has been diagnosed with blood cancer in the past. There are also some disease-specific risk factors. The chronic lymphocytic leukemias have been associated with Agent Orange exposure in the Vietnam War. Epstein-Barr virus, which is a common cause of mononucleosis or mono, can lead to the development of Hodgkin lymphoma. Autoimmune diseases such as lupus or rheumatoid arthritis typically require treatments with immunosuppressant drugs. And these drugs that suppress the immune system can increase the risk of non-Hodgkin's lymphoma. HIV or organ transplant recipients are also at higher risk of non-Hodgkin's lymphoma due to decreased immune systems. And obesity has also been linked to multiple myeloma. So how do these cancers present? So with leukemias, we typically see people coming in with either symptoms of infection, such as fevers or chills, or symptoms of anemia, such as fatigue or shortness of breath. They can also have easy bruising or bleeding from their gums or their nose. In terms of lymphomas, they typically present with what we call B symptoms. This includes night sweats, fevers, and unexplained weight loss. They may also have enlarged lymph nodes or lumps or bumps in the neck, armpit, or groin, and may also present with an enlarged spleen. Symptoms of enlarged spleen can include pain in the upper left abdomen and getting full faster after eating. In terms of multiple myeloma, there is a mnemonic that we use called CRAB, which refers to high calcium level, kidney failure, unexplained anemia, and bone pain. And patients can frequently present with these bone lesions that cause pain. So how do we diagnose patients with these blood cancers? In terms of leukemia, we can typically screen patients using a complete blood count, which would typically show a high white blood cell count with a low hemoglobin and platelet count. We can also look at a peripheral blood smear. And there's an example of a peripheral blood smear seen here. These large cells called blast cells can sometimes get into the peripheral circulation and are very suggestive of leukemia in the peripheral blood. After we do these screening tests, and if we are suspicious for leukemia, we send the blood for something called a peripheral flow cytometry and perform a bone marrow biopsy. In terms of lymphoma, we can also screen people using a complete blood count, but we'll also do a physical examination looking for an enlarged lymph nodes or an enlarged spleen. If we find any abnormalities, we typically send them for a CAT scan or a PET CT scan, which can help detect lymph nodes throughout the body. If we do see enlarged lymph nodes, we will then send them for a lymph node biopsy, which can make the diagnosis of the lymphoma. For multiple myeloma, we can use screening tests such as complete blood count, protein level in the blood, and serum protein electrophoresis, and serum free light chains. This is due to the fact that the multiple myeloma cells produce abnormal proteins. After we see an abnormal protein level, we could then typically do skeletal imaging to detect to see if they have any bone lesions, and also perform a bone marrow biopsy. So how do we treat these patients? So acute myeloid leukemia has had pretty much the same treatment for the last several decades. And that's typically with a high dose of chemotherapy, what we call 7+3 induction chemotherapy. In more recent years, we have found some other drugs that can be effective against leukemias in patients who are not able to undergo this high dose of chemotherapy. And this combination of venetoclax and azacitidine has been very promising for these patients. In patients who are very high risk of a relapse from leukemia, we do consider bone marrow transplant, which is curative in certain cases. In terms of chronic myeloid leukemia, this is caused by a specific mutation in what's called the Philadelphia chromosome. We have great targeted oral agents against the mutation, and this can work for many, many years and keep the leukemia at bay. This drug called Gleevec was revolutionary in the early 2000s because it was one of the first targeted oral agents that was able to treat leukemia. In terms of acute lymphoid leukemia, we typically use high doses of chemotherapy as well. And in patients who are at high risk, we will also send them for a bone marrow transplant. And lastly, in chronic lymphoid leukemia, we have several targeted oral therapies that have come out in the last decade that are very effective in keeping this leukemia at bay and having patients live for many years. In terms of treatments for non-Hodgkin's lymphoma, the treatment is based on the type of non-Hodgkin's lymphoma that's present. For diffuse large B-cell lymphomas, which are the most common types of non-Hodgkin's lymphoma, we typically use chemotherapy with a regimen called R-CHOP, which has been the standard of care for many years. In terms of follicular lymphomas, we typically tend to use chemotherapy as well, but there are more targeted agents coming out for this condition. Mantle cell lymphoma, chemotherapy is still considered the first-line treatment, but is not as effective. So we do have targeted agents that we use in the second line and onward. Burkitt's lymphoma is a very aggressive type of lymphoma where we have to use high-dose chemotherapy for treatment. In terms of Hodgkin's lymphomas, the standard of care for Hodgkin's lymphoma has been the same since the 1980s with a regimen of chemotherapy called ABVD. More recently, we have a targeted agent called rituximab vedotin that has come out and now can also be used along with chemotherapy in the first line. Interestingly, in Hodgkin's lymphoma, we can also use something called immunotherapy, which is basically medications that help our immune system start working better to fight the cancer itself. And this is the only type of blood cancer that has shown to have benefit with immunotherapy. For localized disease, radiation therapy can also be used in all types of lymphoma. And surgery is not typically an option except in select cases. For treatment of multiple myeloma, we have several agents that have been developed specifically for use in this disease. These include proteasome inhibitors, immunomodulators, and monoclonal antibodies. Steroids are also effective in this condition. Chemotherapy was used a lot in the past, but has started to fall out of favor. And in some patients, we do perform what's called an autologous stem cell transplant, which can increase the length of a remission from this disease. So what are the long-term effects of these cancers in their treatments? So infertility is something to be very aware of with these treatments. In terms of chemotherapy, alkylating agents such as ifosfamide, procarbazine, and cisplatin are very prone to cause infertility. They can cause damage to germ cells in the ovaries, cause premature ovarian failure, and can interrupt menses, which can lead to permanent menopause. Radiation therapy to the pelvic region may also cause infertility by destroying eggs that are housed in the ovaries. Bone marrow transplant has also been associated with infertility in certain cases. So there are several options for fertility preservation prior to patients undergoing these treatments. A common strategy is egg or embryo freezing, also called cryopreservation. Ovarian tissue freezing is an alternative to this. And ovarian transposition, which refers to moving the ovaries out of the field of radiation, is a strategy that can be used. Ovarian suppression with hormones can also be implemented to prevent the ovaries from being damaged. There are also some emerging techniques that are being used in certain places, such as artificial ovaries, nanoparticles, and further protective agents. So some other long-term effects that can occur. Getting pregnant after cancer treatment. So most females will be able to conceive after treatment, but it is recommended to wait for 2 years after completion of treatment. That is when there is the highest risk of recurrence of the blood cancer, and also it allows the body to recover from toxic effects of the treatment. So there would be no risk to the fetus. Some oral or newer targeted therapies for blood cancers should also be stopped while pregnant. So that's something to be aware of and discuss with your doctor before you plan for pregnancy. Breastfeeding. Some medication should not be used while breastfeeding, and this should also be reviewed with your doctor prior to starting breastfeeding after treatment for hematological malignancies. Radiation therapy to the chest area can also impair milk production, and certain lymphomas that start in the chest, this can be an issue. In terms of birth control, for all sexually active individuals, it is recommended that you use birth control throughout the treatment period and for a period of time after completion of treatment. There are also other physical side effects that can result from these treatments. These include chronic heart failure, thyroid issues, lung damage, osteoporosis, hearing loss, cataracts, secondary cancers, peripheral neuropathy, which refers to numbness and tingling in the hands and the feet, and an impaired immune system. There's also something that they can also affect your cognition, including impairment of concentration, memory, and the ability to multitask. Some patients do have psychological effects from these treatments, like depression or PTSD. And there is a financial burden associated with some of these treatments, as the newer treatments tend to be very expensive. There are several resources to help manage long-term effects available to patients. The Leukemia and Lymphoma Society is one of the top organizations to help manage long-term effects. It's the world's largest voluntary health organization dedicated to funding blood cancer research, education, and patient services. And the contact information is listed here. The International Myeloma Foundation is also an organization for patients with multiple myeloma that can be very helpful in helping to manage long-term effects. And the American Cancer Society has patient and caregiver support resources available as well. There are also several resources to help manage fertility preservation while undergoing these treatments. Path to Parenthood, the American Society of Reproductive Medicine has facts listed online. The National Infertility Association can help patients find infertility support groups. And there are other associations that have information available for women who are undergoing cancer treatments who would like to preserve their fertility. Thank you very much for your participation, and I hope this session was informative.